if you remember last week, first place, happy Monday. We're going to do the COVID slides at the end like we did last week. I think I'm taking a few weeks off at the end of August, but a few weeks off the webinar, not literally a few weeks totally off. But anyway, what I wanted to share with you is I'm hoping the following weeks, one of the guests will be someone who provides services and someone else who'll talk about, we talked about self-directed services earlier and individualized services, but we didn't talk about the money part. And what we're going to do today is take the things we talked about last week about the state budget and Medicaid budget, both and DDS budget, and we're going to make it more specific about how rates work. So it's a little not as good on pictures, but more on facts. And what we'll do is allow time for talking as well. And then at the end of this, after we do the COVID slides, if people want to talk about their reopening experiences going either to work or a day program, how it's been, or family members want to share about that, would love to see that as well. Okay, so that's the game plan for today. And I already just did this, so we'll go right to the show. Okay, so this, I used this last week. Again, just gives you the frame for DDS dollars in a whole bunch of areas. And technically the DDS caseload is 44,000, 45,000 people. We think there are probably 200,000 people, children, youth, and adults with intellectual developmental disabilities, you know, the whole range, autism, cerebral palsy, Down syndrome, Williams syndrome, so many different, you know, possible, diagnoses. But having said that, we know that the DDS caseload is under 50,000. We know it's probably heavier on adults than kids, though there's quite a few kids historically on the caseload because of family support services, because of DESE, which is the Department of Education, Elementary and Secondary Education with DDS program, and because of the Autism Children's Waiver. And so between those three offerings, you know, kids are part of the DDS world in terms of funding. Mass Health, of course, is the other place in the long-term supports and services. So this is an example. So this is where the new slides start. Here is an example. I'm comparing today program budgets, right? And individual experiences in programs or service settings with more individualized budgets. And again, you know, we're gonna show you this because what I want you to see when there's a program budget, that it's not just the direct support experience that the funding is paying for. If you look at this sheet, it talks about the interdisciplinary team that a day hab program is having. I'm using day habilitation as an example. People are primarily in DDS community-based support, or they're in employment through DDS, or they're in day habilitation, okay? And under employment, there's categories. I'm not gonna get into that. And then there's adult day health, that as people get older, they end up in that mass health program. And then from an individual side, obviously, there's a few different options for services, most of it through self-direction, but not all. And that would be through participant-directed program and agency with choice. But there's also things that people could patchwork together through support services. And there's something called placement services, where someone lives and is helped in his or her own apartment and may have a roommate, may not have a roommate, but they're not getting 24/7 support. But if you look at this program, it's not just about the direct service, it's also what are the other services that they're required to do. Whether, you know, and I'm not getting into whether they do it well or not, we're just talking about the funding and conceptually what's going on here. And then, sorry for the language, you don't have to read it, you're gonna get this. There's program site, so when you have a program, what happens with that, whether it's residential or day, you're maximizing the number of hours that you can get for services if you're the person, if you're the program participant. From a family perspective, if someone lives, is getting assistance or goes to a day program and lives with family or a friend, and that person works during the day, the friend, and they can't be home for whatever reason, or they get bored for the day and they want to have maximum interaction during the day program covers 6 hours, and then there's the transportation back and forth, right? So that's sort of the dynamic with program sites, whether it's CBDS or it's day hab or adult day health, you know, and in residential, you know, we'll talk about it a little later. It's some of the same principles. I'm going to make my participant screen smaller. So when you look at, you know, group residential is the same thing, where they take 4 or 5 people living in a residence, and they basically say, okay, you're getting money for 4 or 5 people. It's usually 5 nowadays, usually no less than 5, just to make the numbers work. When it first started in the old days, it was 8 people, believe it or not, in a community home to make the numbers work. And that's a lot of roommates to have, a lot of potential arguments and conflict, and a lot of matching to have to do. But bottom line is that those dollars that they get for the individuals have to then be crafted into the cost of a home, the cost of staffing in the home. Well, the same is true for day habilitation. So using day habilitation as an example, the agency gets $4.28 for 15 minutes. This is the last rate that had been promulgated, which was in 2018. Then I sort of play that out to say that means for one person for a week, it's $513.60. $513.60. Now, what I want to make clear is people aren't necessarily billed 6 hours for the full day, because maybe someone leaves early. Maybe the bus is late. That's why programs hate it when transportation is shoddy, right? Because the person's not in the program. They're in there 5 hours instead of 6, but they're dependent on that revenue to run the program. The other thing is people that are documented to need one-to-one help to eat, so they won't, you know, have a problem choking or aspirating, or they may need help in other ways. DDS provides what's called a Wrap. That I didn't write that down here. That comes from DDS, not from Mass Health. Mass Health pays for the day have program overall, but the rates are such that if someone needed one-to-one help for eating, that's not built into the rate. So therefore, there's what's called a Wrap funding, and you know, if it takes half an hour for lunch, you're only going to get 30 minutes. You're not going to get 35. If it takes 25 minutes, you know, they're going to judge what you need for that eating or whatever else activity it is. Someone doesn't automatically get one-to-one help for the day just because they need help eating. Some people may get one-to-one for the day because of behavioral conditions, complex behavioral conditions. So here an agency's taking that $513.60, and they're going to try to figure out how to run a program on that, and basically multiply that, you know, by a number of people and try to figure out the implications for running a program. In the case of the PCA program, I'm picking another Mass Health program because it's so stark and distinct, the PCA versus DayHab. So it's easy for me to make that comparison and explain it. In the case of, you know, and this includes DDS self-directed supports, DESE, autism children, they're all examples of individual funding. And I call that going retail, where the state is, you know, not going through a provider. A provider may be involved, but a provider isn't essential to the service in the sense of having these other supports and having a building and all of that. What they're doing is you may have to go for a provider, through a provider for the monitoring and the fiscal agent and those kinds of things. But as a rule, the agency costs are much lower. In the case of personal care attendant program, the agency rate is a separate rate that what they call the PCM gets, personal care management agency. It's actually not even built into the rate for that person, their management costs. What is built into the rate is an additional charge for probably payroll taxes and things like that. And I'm not showing that. I think the full rate is $17.80 an hour, of which the difference between that and what you're seeing at the staff rate is $15.75 an hour. The differential is what goes to the agency. That's the modest overhead I referenced. But really the point of the program on all those cases are either, in the case of PCA, it's all about staffing, right? You may get there's other rates for orientation time. I think the maximum orientation time is like 4 hours, and I would have to look that up. I don't have it in front of me right now, but it's limited. It's not like 2 weeks of orientation, okay? And maybe you can get approvals for that if you go to your PCM agency, but all these hours that you might get, they have to be approved first by your PCA management entity, and then they're reviewed by Mass Health. Mass Health has hired another company to do the review because the reality is Mass Health had a handful of staff to oversee these programs through the Office of Long-Term Supports and Services. So 3 years ago, a decision was made to hire an extension of Mass Health, a private organization, healthcare agency, to monitor all of their OLTSS services. So in the PCA program, only staff costs are really figured in, but in programs like DESE, and Kerry, you know DESE well, and self-directed support programs, you can have built into those, essential materials, right? Supplies that you need. And that would be part of your personal budget. So you're really looking at, different ways when people are concerned. And the reason this is a great time to talk about this is because of COVID and the fact that half the people aren't going to be going back, right, to day habilitation. It really isn't like, there may be ways to make the day hab work for individuals. And we're talking about that as part of in-home strategies, but there are existing in-home supports and services. They're based on a different model, and they're based on different funding cycle. And again, if we go back for a second to look at the day hab dollars, that's $4.28 for 15 minutes. Obviously, if you multiply that by 4, right? Just think about that. That's about $17 and change, right? Ironically, a PCA all in is about $17 and change, including the small percentage. So when you look at that rate, this is the high rate for day hab. You're saying, oh my God, if it wasn't like they're actually paying them the equivalent to also have support staff, to also have interdisciplinary team, to have a supervisor, and they're paying them the same dollars that they're paying for PCA program for an individual. If you look at the dollar, hour for hour, dollar for dollar, and it helps you appreciate the funding level of the day habilitation program or any day program, and how it's built on numbers, it's built on people in a setting, and we'll talk more about how these things happen. So any questions so far? Because I don't want to, this is like stuff for the first time where I'm getting more granular. And we're talking about a range of programs. We're not just talking about one program. We've done these trainings about specific programs, but I've never gotten this granular trying to address program versus individualized support. So, and try to help people appreciate the different presuppositions that are there. Any questions so far? Is it making sense to you guys? Carrie, can you see if anyone's chatting in? And
yeah, I don't see anything in the chat box, Leo.
Okay, so I'm going to keep going. It's a different way of presenting, Kerry, right? We've never sat down and we've talked about specific programs, right? But never taken it apart this way, even though, we know this information. So
Yep.
There's a wonderful example of when this speaker rate is part of CBDS or DAF, someone's going to go out on some kind of plane ride, right? And it's a little nervous, but they're helping him get into the plane. So here's some points that I want to cover, and I got to push this thing out of the way again. I'm sorry that it's cut off at the end. So some comparison points between the two examples I just walked through, okay? And I've sort of touched on this. Number one, you're talking pros and cons. You're comparing coverage of hours, right, in a day or overnight, 24/7 for residential, versus less hours with more training and inclusion opportunities. Now, I'm assuming B, right? I'm assuming that if you're developing a person-centered plan and you're in a self-directed situation, or you have your own PCA, right? If we use the PCA program that I used as the examples, that you're going to be able to do more things that are your preferences and that also truly match your needs. I'm making that assumption. And I know if you can't fill your PCA hours, that's not going to happen. But that is the assumption. Whereas whether it's 24/7 residential, right? And you may not need 24/7, you might only need 14/7 or 10/7, but it's really the coverage of hours that's in play here, right? Bill lives with his sister who works full time. Bill's got to get in to his day program because the last time Bill was alone at home, my God, it was a heck of a day, and sister had to come home early. Bill was never, fully supported to live on his own or independently or had impairments that interfered with that. So the coverage of hours is really important to Bill's sister because of their day-to-day routine and just reality. And that's going to be a decision point. And that applies if you're in a group and the funding is what it is. It's going to be, partially about cost efficiencies. People are going to care. People are going to have a service plan for you that's somewhat individualized. But that is what it is, and you're going to build relationships in the group. You're going to a day program or a day habilitation. You're going to miss your peers. You're going to build great relationships, hopefully, in those settings. If you don't, you're going to want to leave it anyway and go to a different setting because it's not gratifying. So there's plenty of quality indicators in group settings, group settings are going to be relevant forever for certain folks that have certain decision points. But typically, the individual options are going to allow for more social inclusion, both with people with disabilities and without. You may be able to see your friend that you went to school with, and that you've only been seeing once a month because of scheduling problems and not having staff to drive you there, and you don't drive and the bus is too hard. So there might be things you can do through individualized supports that you can't do in the group, but you're probably going to have less hours covered. And when I say probably, most likely you're going to have less hours covered, okay? Because that's the trade-off that plays in. And for a lot of people, it's not a bad trade-off because they can do things somewhat independently for some of their days, despite needing supports and having, moderate requirements for support services. So, and then these are some links that I'm giving you to look at, whether it's the day-hab services thing, adult long-term services rates. The adult long-term service stuff for residential is very complex. There's all kinds of formulas for all kinds of staffing. There's EOHHS administrative bulletins that talk about rates and what programs are funded at. And this just is to, probably reinforce what I'm sharing with you. I don't expect most people to go to 1, 2, or 3. Number 4, we have a site on self-determination where you can learn more about that. I did not double check all the links yesterday, but I think most of them still work. I did check this link, number 5, which gives you sort of some suggestions about how to develop a personal budget and get into that. So obviously it's harder to do. You're getting, those links because individualized options are harder, not easier. So that you have an option to look into that. In terms of group options, you can go shopping. You can basically, if you don't like the day habilitation or CBDS program that you're at, there's nothing stopping you from saying to your service coordinator or saying, service coordinator or even with Mass Health, you can look at a different day habilitation programs. You might have to ask for a list and where are they, and then just evaluate for yourself the differences. And I know many people do that when they turn 22. I think fewer people do it to transition, but that's always a possibility. And then one other thing, that I jumped over last time. This I always say this has got to be updated because we've got Adult Omnibus, which really needs its own track right here. It's sort of like, to me, Adult Omnibus is not a similar residential option, but it is a community living option that should probably go in here or in here. See my pointer? Can you guys see my pointer? I know there's a thing someone told me the other day. I can mouse. Okay, so I hit mouse. So hopefully you can see my pointer now. Oh, sorry. I don't know if you can see my pointer. Yes, no, Carrie? As I point to things?
Yes.
Okay, good.
Yep.
Okay.
Yeah, they can see it. We can see it. You do have a question.
Yep,
a couple of them, actually.
Okay.
Beth was wondering, you're just saying that this is really helpful information, what the prospects are for increasing direct support providers' hourly wages.
Well, so the fantasy we have here that we had in 2018 when we finished, preparing the workforce report that we had, I think was the only way we're going to solve that issue is building more self-direction options for people. So people turning 22 and people living today in 24/7 residential that may not need 24/7. Choose more self-directed options or different housing options, supported living, shared living, because then what's going to happen is going to shake up the dynamics where you're going to have, right now, residential costs of a residential home 24/7 is already, in the light of COVID, very expensive, and So we would love to see some systems change where those dollars that are invested in bricks and mortar are invested more in the salaries. And it's not a panacea. It has to be done carefully. It's got to be done creatively. We also started with DDS and the Trade Association, ADDP, a task force in the fall. We were actually advocating it for over a year and a half, a task force on innovation and technology. So we would have a report where we talk about not just, for the last 4 years, they've talked about shared living, and we've made some progress, and we've talked about self-direction. I'm really pleased that they just appointed a new, we'll have her on soon, an assistant commissioner level, I think deputy assistant commissioner level for self-direction, Liz Sandblom. And I think they're going to make a renewed effort to build those services, because then what you can do is pay direct support professionals more, Beth. And, we build models that are all about that. And we then have a better distribution so we can raise salaries in the traditional sector as well. Our projection, even for a partial addressing the problem, somewhere in $500 million ballpark for the salaries, okay? Just to give you, a sense of it, because you want to also address frontline manager salaries, and you're going to end up having people with experience. You have to think about people you want to keep that have worked in the field for 10 years. How do you pay them differently than, someone at the entry level? So that was just to get the ball going, There was going to be an investment. So let me give you a comparison to that. We were very thrilled when we were told there would be a 10% increase for direct support. Well, not for direct support, for what's called ALTR, alternative long-term living arrangements, basically the residential services, not just the DDS, but in this case, it was mostly at DDS, a little bit at MRC, a little bit at Mass Commission for the Blind, but the lion's share of $125 million for a 10% rate bump was going to be at DDS. And that was going to eat up almost all of the rate reserve, by the way, for this year, and did, because technically, I think that rate stands for the coming year, for 2021. When you get a 10% rate bump in residential, if you assume 70% of your costs are personnel, you're potentially talking about anywhere from a 6.5 to 7.5, maybe 7.2% increase in salaries. Now, what works against that increase, you have a couple of percent that's going to go to housing, occupancy, fuel, gas, you name it, though gas has gone down in price. You're going to have the impact of the damn cost of health benefits, right? So, and those have been going up pretty well, even if going up much less than 10 years ago. They're still going up 6%, 4%. You have a few examples of cancer, even in a large agency, and your rates are going to go up. So you basically are dealing with these metrics. So that was like a win for us from our perspective, because, it was going to be important to have that rate be as high as possible. And we felt like just salary alone needed each year a 10% jump. That was our advocacy cry. And again, we were thrilled that the report showed, at least a 10%. That was the minimum that we felt made sense. And if you recall, the allocation was $160 million for that line item across, I don't know how many services. And we said, that's fine, but, we're going to need 10% of that. I mean, not 10% of that. We're going to need most of that just to reach the 10% number. And before we knew what the rate allocation was going to be, we had advocated for that 160 to become 220 million, so there could be equity with other agencies. So obviously COVID then got into it before the other rates were established, and I'd be shocked. So, but next year is employment and day services and family support, I'm pretty sure rate increases. So, I'm not sure where we'll be next year because of the deficit, right? And that would be to take effect in 2022. So we're facing, in the short term, we may have more people coming to work. In the long term, they might be a quicker cliff losing people if the economy rebounds over the next 2 years. So workforce is still a huge priority for us, and, really important. Carrie, is there anything else before I go on? I'll look at the
No.
chat. No? Okay.
No,
And
I think we're good.
this chart just gives you a feel of the range. And again, I'd have Harry, we're going to have to put on 8x14 or something, huh? The autism omnibus.
Yeah.
The next time you see this, we're gonna have the chart finally updated, because I bet you, we updated it when the bill became law, and then never got around to the design. So we had our questions, and again, this is more complex. So I'm hoping we'll play this out, and I think the future is about more self-direction, more supported living, so we can pay people more. So as everybody knows, you already know this. You know that there was more new cases, 900 more this past week. Now I'm counting one more day, by the way. I don't know how that happened, how I didn't use 724 as a pointer last week, but I didn't. So there was 2,100 new cases, 2,103 if you want to be exact. And last week, there was only like 1,190 or something, 80. So it says 900 more cases. So than last week. And I don't have my Excel chart in front of me. Testing wise, we're going at a clip. There was quite a few new tests in the 8 days, over 100,000 new tests. And then 124 deaths, which is again, 43 more than the week before with the additional day, which feels, now it feels like a lot, to be honest with you. And so I think we're in a test area where the governor just put out, I think the other day, besides the August 1st announcement, he put out something about events. We were invited to an event, and we were probably going to stop, drop off some cards, and move, leave. And we weren't sure we were going to do that because there was going to be, more than 50 people at the event. It was going to be crowded, and even if it was outdoors, which I expected it would be. And so it's something that was going to be this Saturday, and it's been canceled. And because of this, the spike and the governor's outreach to stop, having gatherings that are, large. And so it's something, I think it's so important because we know people with disabilities, and we know older citizens, older Americans are more at risk with this virus. And, people are expecting November for us to see a surge, and hopefully that won't be the case if we're wearing masks. I mean, the information, that's why I wanted to show our site, Carrie, it's a site to coach people with disabilities about masks and distancing and all of that. So, and it's really good because we're using information from other places. We stole, we borrowed, and we also put up some pictures of our own that we got off the web to really help people with disabilities also appreciate the need for distance and the need for masks. It's scary. And then obviously if someone can't wear a mask and they're out, I can tell you I was walking around Boston yesterday for an hour, took a bit of a break, and it was pretty scary because I say scary, my wife gets more scared than me. We would walk by people, they had no masks. This is in Boston off of Boylston Street. And it wasn't so much the mask that bothered me, but people would be yapping away, right? Sometimes their head turned toward us within less than 6 feet. So we figured out a way to avoid the crowds. It's still not overly crowded, thank goodness. So it's something to think about for our loved ones, for our parents, for, something to stay on top of. So anyway, that's obviously a big thing about reopening. And on the dashboard, just so you know, July 30th report that I saw, there was 10 positive client cases in community homes. There are no deaths in the past week. And then staff facilities report less than 5 positive cases in each setting, and no client positives reported at state-operated homes at this point. So the 10 positives are in provider community homes, and that's out of, again, 7,000 something settings. I told you last week, deaths-wise, we probably had 100, and maybe by now between 100 and 105 people have passed away due to the virus. And again, I can't give you an exact count because of the way that the data is being reported since early June. But that dashboard, you'll get the link again. So, and this chart is a little different than last week because I updated it with July 30th. So reopening, we have about 10 minutes or so. I'm going to spend a couple of minutes, just talking about what we know so far about reopening. And I'm going to cover in probably less than 5 minutes. And then if some of you are out there that have started to reopen or have some reopening stories, or you want to share your preferences or goals, I'm going to just have a feedback time with those of you that are on the call today. I think there's about 45 people left on the call. So I welcome the discussion through chat or putting on your mic and chatting. So first, the update. More agencies open this week. Last week, we had 20-something agencies in terms of the Dayhab world out of 178 sites that had opened. This week, several more organizations are opening their sites. However, I would say there's still agencies that are hustling to get their sites open week of August 10th or August 17th. There's some rare instances, not rare, they might not be that rare, but handful that I've heard about, because I haven't heard about them all, that aren't opening till September. In the meantime, some of the conversation has been, geez, if we're expecting a surge, why are we reopening now? And all this effort and work. Now, I can tell you, in the cases for the folks we heard from Chris last week and his colleague, how much people wanted to return. And other cases we heard where people are scared about returning because of potentially the virus, especially if you're living with older family members. Returning has to be weighed carefully. On the other hand, agencies are checking, they're doing, the average story I hear is pretty intense checking. So I want to add something though to this issue. One of the things we're advocating for is to figure out an in-home strategy. And my hunch is HHS might have already figured that out or might have one to share. I have a call later today to hear about potentially some changes. I do know, let's look at a few facts. We know that 60% or more than 60% of people will not be in their day or employment setting. If they are in there, they're in there half a week. Okay, so people will be going 2 to 3 days, and then the other people will be going 2 to 3 days. The negotiations around financing with the state has been around how the state can pay providers. And remember the example I gave you about billing for Dayhab, and this goes for CBDS and employment. You can have a contract that covers your costs, but if you can't bill by 15 minutes, you've got a problem if you're losing half a day for each person. So, or you're losing 2 days for each person. So the state wants to keep some remote. That's, there is no final agreement yet for August 1st on, and I know today's August 3rd, right? But the expectation is that there'll be some kind of agreement with both a combination of in-person and remote. And we're advocating for, thirdly, an in-person that's more individualized, or people meeting without walls, 2 or 3 people together, meet a staff person. So it's got to be carefully figured out. And the other thing you should know, Beth asked earlier about staff salaries. Some of our staff, they may be good in a program setting, but the idea of working more independently, right? Whether it's in home, the family home or community residence, or it's in situation where you're meeting people in a community setting without walls, that's more responsibility, and you have to make sure people are trained. So it's not a simple matter. Tomorrow I'll be doing a presentation, State of the State, for the Arc of Plymouth and Upper Cape, and we're going to get into some of the things that folks have been working on. And if you're interested in that, we'll probably, you can access that through the Arc of Plymouth and Upper Cape and see if, where they're promoting it and how to register. But they might have a certain capacity limit on who can attend, but looking forward to getting a little more in depth on those issues. And it's really, you've heard a lot of it from me before, because we've sort of, either Maura Sullivan or I or Kerry have talked over time about what's going on and sort of the different things going on and negotiations. So we're still in the midst of, working with the state and the ADDP, which is the Trade Association, and others to figure out, okay, what is going to be the way we're going to approach this between now and at least November, maybe December 1st. So that's what's in play. And remember, the state only passed a 3-month budget. So, it's only that sort of affects planning as well. So who would like to, anybody want to share about any experience you may have had? And I'm looking with Kerry at the chat, and Alice, day program opened for my son, and one of his roommates who attends the same program came as a bit of a surprise. He'd been going directly to supported employment 3 times a week. Oh, so that's great. So he was still involved in terms of working. And
He started back to
a
work.
little louder, Alice, a little louder if you can. Started back. Go ahead.
Started back to work in late June,
Okay.
but going directly to the market basket from his residence and then directly back to his residence at the end of his shift. So going back to an operational day program, we didn't know when that was going to occur. So when they did say, okay, we're starting back up tomorrow,
Right.
and you know, fortunately, it was okay for us. The online thing just was not working for him. So and I had a chat with the other mom, with the other family, and they were good with their son going back as well. So they're still kind of in a bubble, and they're still kind of in a bubble, I think, at the day program as well. Not with each other, but you know, they're in different locations. But everybody's working hard to make this work, and we're just very, very happy.
That's great. Yeah, it's hard, and shows you how hard it is for them because you didn't have a lot of notice. You had very little notice on going to the day program. Hey, Anna, how you doing? And also Diane wrote, in-home strategies are needed, and even suggests like remote speech and physical therapy. Yeah, and that's, I assume you mean like a physical therapist saying you could do this or that, you know, to help keep the body going. I think it's really shows how overwhelmed the agencies are based on Alice's experience, and they're trying to be safe. So as soon as they knew they were safe, they pulled the trigger. And then Diane, did you want to add something to that, or are we good on that?
Well, no, I was just, you know, when I said speech and physical, I'm just saying for the older folks who, you know, it's tough to remain active if you can't go anywhere. And if you're home with 2 other family members, you're not exercising, you know, a lot of speech skills. So it's just something to think about when you're weighing. When folks are weighing, I know people use the expression, we're weighing regression against risk. And, you know, I I don't think we should be put in that position. I think we should be able to maintain skills and not have to think about, am I going to choose, you know, potential loss of skills, which we're not experiencing yet, with risking one's life. So, you know.
Good input. Thank you, Diane. And then Herb mentioned Services for Joe started up again in June, and he's on a self-directed program, but not going back to work at the restaurant yet. Well, restaurants must be struggling like crazy. But he's been primarily community-based locations as well as online learning. He's about, oh wow, 60 to 70% of the hours prior to COVID. Okay, wow. So that's actually impressive that he's almost at 70%. That's awesome. And again, that's self-direction for you though. You know, we're doing the comparison with the group. So he's made some trade-offs. Joe has, and Herb has, and his family, right, for self-direction versus the group experience and the coverage. But it is a change, and he's hoping to ramp up hours to the prior level in the next 2 to 3 weeks. You know, I was thinking about that. Yeah, go ahead.
It's been a real advantage being on a participant-directed program because, you know, we're able to hire our own staff. So it was kind of up to us when we turned that back on again. So it's really worked.
Did you almost lose staff? I'm just curious. Back.
We've been lucky. We've been able to maintain pretty much the same folks. It's primarily one individual provides most of that support, but for the most part, he's had that in place. He's also got a transition going on. The folks who lived with Joe in our house when they moved in have now bought their own house. And they are actually taking Joe with them to their own house. So he's going to be up for a transition here in the next couple of weeks, going to a different house. But he's all thrilled about it, and so and as are we. So he's got a bit of a transition to go through, and the staff now going to a different location to get him has a little transition to go through, but it's all good. So we're trying to ramp that back up.
So, and then that's great, Herb. Thank you for sharing that. And then one great suggestion that I got privately is about the folks that do get that wrap. I referenced the DDS wrap before, those that have it for a longer day. So here's the thing, depending upon why they have that wrap, the question is, couldn't they have some kind of in-home experience or individualized out-of-day program experience where they have a wrap and spend the day off site? And yeah, I mean, theoretically that works. But if the reason for the wrap is behavioral and the one-to-one is a question, right? So maybe it's, 2 hours, 2.5 hours, or a few days a week, 2-to-1 staffing, right? So it wouldn't be the whole week with the wrap. And remember, the wrap is on top of what they get for the day program. So maybe a partial week with 2 staff if it's significant behavioral issue. And again, that depends on the person and their needs and their desires. But I think, yeah, I know the wrap though. So this is the interesting thing with the agencies, what I've heard is they actually need that functionally to serve who they're serving because of the lack of funding during this, reopening process. Because they're not getting 100% of their dollars during reopening, which you would expect them not to anyway, right? But then how do they pay for the fixed expenses and the staffing they need that may not be 100% of what they had, but more than what they would need for the percentage of people there. And then Judith Doherty, oh, I said a last name, sorry about that, Judy, but everybody can see it on the chat. The issue of those resident homes and agency without day services remains, and in-home day support for multiple agencies. Yeah, so there is, so the first part of her point, actually there's potentially a conflict, right? People who are home that are being served residentially, that residential provider may want to do it, right? They can exert more control, so it's not. And where that becomes a conflict is the folks who are being served by agency Y, and they will no longer potentially be served by agency Y. And I think that will cause, the normal political conflict with a small p that we could imagine would happen, right? And then the other issue, and you're right, is about families with kids turning 22. And the parents should be worried. I think that's something else we've raised is, what do you do in this interim period? And we've actually been talking with our chapters about a collaborative project where everybody would buy in. And we're actually meeting on, we have more than 50% of them that are open to doing this, creating a space, bigger space around self-direction strategy for those turning 22 and offering that as a possibility. And of course, other agencies could do that too, because I think it's really important to start thinking about that. And, but because of this crisis, I think we just have to be open and different. And obviously then some of them would refer the folks to other agencies. It wouldn't just be chapter oriented, but the chapters would have a space to do the self-direction using Charting the Life course. So that's what we have in play that we're going to talk through today, actually. So, we have obviously other agencies that we're very close to that we hope to talk about that as well. So I think we hit our 12:45 on the button here, guys and gals, I should say. I'm always said guys growing up in New York City. I want to thank you all for being with us again. I'm looking forward. Remember, a lot of these are on the web, the Trauma Informed Care, the second series is on the web. We're going to have other sessions. Terry, tomorrow, are you, I know Maura's off, I think, for the next couple of weeks. I think we had announced that. But Carrie, any plan for tomorrow? She's got to unmute herself. I know she.
Oh, yeah. So, hi, this is Carrie. Well, tomorrow at 11, I'm having a guest, Christopher Claxton, who's the ombudsman at the Department of Developmental Services. So he's going to be talking a little bit about what that role is and how families can utilize them. So hope you get to join us.
That's great. That would be great. And I'm glad. Chris has been hiding out for a while doing other stuff because of COVID. So it'll be great to get him talking about his role. And great being with you guys. I see a lot of familiar faces as usual. we'll hang in there together and look forward to talking to you next week again. And feel free.
Leo, when you go,
Yeah.
when you taking off, Leo?
End of August. So I'm going to there'll be 2 Mondays in August. The first Monday, not the first Monday, the last Monday in August, and then the Labor Day will be off, and then I'll be back. So I'm not taking 2 weeks physically off, but I'm just that very last Monday, and we'll announce what that is. But up until then, I'm going to go straight through and then restart again. I think 7th is a Monday this year, if I'm right, if I remember right. So the second September day I'll be back. So just taking a 2-week Monday break, and we'll try to do. Obviously, if anything happens during that period, I'll be on. But my goal is to take about 7 work days off between the end of August and Labor Day. So, and then be back, if no emergency happens in between. So, assuming that. All right, hope everyone's having, and we got to continue to work on a bunch of stuff, and we'll talk to you Monday about that. And again, is this topic, can I get you some quick feedback if I have a guest on to talk some more about the funding and how it works? What do you think folks got what they need to know? I'm sure just on that comparison, would be good to talk about self-direction more and putting a personalized budget together, things like that, and how that gets worked out. What do people, if you can either chat it in now or say something now, but I do want to think about, to me, like, the budget is very complex, and yet it's the most important thing we can advocate for. And right now during COVID, and to make sure services don't slip any more than they have, and that they're reinstituted the way they should be. Obviously, special ed and the federal fight right now is really important too. Get the Democrats package in the House. It's a richer package for us, our services. There is no package for us in the Senate right now. So it's really important to get Republicans to accept that in the Senate. And that's not a partisan statement, it's just the reality of who controls which branch and what's going on. So, all right, everybody, take care. Look forward to seeing you next week. Bye-bye.
Say bye again. Bye-bye.
Bye, Anna. Take care.